Good morning or good afternoon or good evening, everybody. I can't hear you, I can't see you, but my name is Marc Benninga and I'm a pediatric gastroenterologist from Amsterdam. I'm very happy to I don't know if you can see my face now. Here I am. Hello, everybody. So I will discuss with you functional gastrointestinal disorders in the first 4 years of life, and particularly the new Rome 4 criteria. And if you have any question, please ask them. And we decided that I will answer the questions after the presentation. So hopefully you can see me and hear me clearly. And from now on, I will show you the presentation. Okay. So the outline of the presentation of today is not that difficult. I will discuss the Rome 4 criteria. I hope you are familiar with these new criteria. And as you will face, there are many different criteria mentioned, but I will highlight during this talk regurgitation, infant colic, and constipation, because these are probably the most frequently seen clinical entities in your daily practice. So first of all, I'd like to discuss with you the history of the Rome process. So as you can see from the left of the slides, it already started in 1989, and at that time only adult gastroenterologists were involved in making new criteria for functional gastrointestinal disorders in adults. So children at that time were completely ignored. But in 1999, a group was formed which consisted of different gastroenterologists, and they made new criteria for children with functional gastrointestinal disorders. However, because good studies were lacking, we most of the time copied the criteria as were made by adult gastroenterologists. And then in 2006 and 2016, we made new criteria, and there were two groups. One group discussed the criteria for infants and toddlers, and a second group looked at the data in children and adolescents. So in 2006, these criteria for the first time were published in Gastroenterology, and in 2016, all these criteria were revised. And as you can see on the slide, there's also a specific book made about the Rome 4 criteria, in which you can find all the important data about infants, toddlers, children, and adolescents, which are not described in the special issue of Gastroenterology. So this is this specific issue, and this is the particular book which you can order through the internet if you're particularly interested in these very common functional gastrointestinal disorders. There are lots of other products which might have helped for you, like algorithms made how to diagnose and how to treat different entities. And also, if you're interested in doing research, then there's a specific book with questionnaires which are used often in research today. So if I summarize what happened in these years, the criteria have been refined if we compare Rome 3 criteria with the Rome 4 criteria. There's a section on neurobiology and the development and assessment of pain, which is completely new and was made by a psychologist working in Boston. And especially for those of you who work in the area of infants, this might be really helpful to look at pain in these particular very small babies. And he said he wrote a really beautiful chapter on this specific assessment of pain in very young children. Then we discussed for a long time issues related to feeding disorders. But as we looked at the data published today, then we came to the conclusions that only psychiatrists made criteria for feeding disorders in children. So this means that data made by pediatricians or even pediatric gastroenterologists are completely lacking. So we were not able to make these new criteria for functional feeding disorders. But hopefully in the next 10 years we come up with new criteria also for feeding disorders in children. But at this time we didn't do that. So as you can see from this slide, these are the functional disorders in infants and toddlers as we can see in the first 4 years of life. And as you can clearly see from this slide, it's divided in children with regurgitation, rumination, and cyclic vomiting. G4 deals with infant colic, and G5, G6, and G7 describe the different defecation disorders in young children. And then, although I have no time to discuss this today, of course, there are also new criteria made for children and adolescents, since we only discussed the younger age groups during this presentation. And what's highlighted here is that we now have a new group of children with functional nausea and vomiting disorders. There's a group of children with functional abdominal pain disorders, and of course there's a group of functional defecation disorders in the older children. What's new compared to the Rome 3 criteria? As I just told you, functional nausea was never discussed in children, where it was in adults. So we now have our own criteria for functional nausea and functional vomiting. And currently we are performing a large randomized controlled trial in which we compare the medical treatment of functional nausea compared to hypnotherapy. And it's a little bit a shame to tell you that today there is ever been a randomized control trial looking at the efficacy of any drug compared to placebo in children with functional nausea. Then if we look at the functional abdominal pain disorders, there are also two new groups, which means that there is a specific group, subgrouping for functional dyspepsia, where we have acid-related symptoms, and there's a group with functional dyspepsia and more motility-related symptoms. And as you can appreciate, that the therapy for both these subgroups is different. So to my opinion, it's very important to make these subgroups if you think of functional dyspepsia. The same is true for irritable bowel syndrome, and as you probably know, irritable bowel syndrome is abdominal pain with either constipation or with diarrhea, or the most difficult group is those children who have 1 week constipation and the other week diarrhea. And as you can appreciate, then it's clear to all of you probably that in children with constipation you need a laxative, whereas in children with diarrhea you probably don't want to give a laxative. Okay, so this slide again summarizes the most important groups in children and adolescents, and completely new for you is functional nausea and functional vomiting to work with. Again, this is a very important slide which you probably need to discuss with your patient. What does the slide shows you? Well, for instance, if we look at infant colic, this starts most of the time during the first 2 weeks of life, but as you can see, it completely resolves after the age of 5 months. So therefore, it's very important to discuss with your patient that some of these functional gastrointestinal disorders only last for a very short period, whereas, for instance, functional constipation, you can start to have constipation when you're very young, so in the first month of life. But if you're unlucky, you can have still the same symptoms after 18 years, and you have to refer this patient to an adult gastroenterologist with the same symptoms as 18 years earlier in life. But again, if you look at the slide, then you will face the functional abdominal pain disorders, which starts, to our opinion, at the age of 6, because before the age of 6, it's very difficult to have a reliable medical history from these patients. But again, of course, you can have irritable bowel syndrome from the age of 6, and you have to refer the patients when they are 18 having exactly the same symptoms. Is it common to have these functional gastrointestinal disorders? Well, as you probably know from your own practice, you see these patients daily, and not one of them, but many of them. And you know, if I look at the countries I visited in the last 10 years, whatever country, they always told me that these particular functional gastrointestinal disorders are main parts of their work. And this is showing on this slide as well. As you can appreciate, most of the functional gastrointestinal disorders are very common. This is a recent paper from the United States where they compared the Rome 3 with the Rome 4 criteria. And as you can see from this slide, functional constipation was in the United States the most common clinical entity together with infant regurgitation, and this didn't differ if we compared Rome 3 with Rome 4 in infants. And the same is true for toddlers, where functional constipation was the most common functional gastrointestinal disorder in children, in toddlers. So this slide again shows you that Rome 3 to Rome 4 didn't change that much, but that all these different clinical entities are very common in daily practice. There are, of course, if these clinical entities are very common, then the costs are also very high. And as you can appreciate, this is a paper from the UK. The total costs of functional gastrointestinal disorders in only infants is already 72.3 million pounds per year, which is an enormous amount of money for these kind of disorders. And you can see that there are, on this slide, I listed the number of admissions and the mean length of stay for very easy problems as colic, as constipation, but also very high number of admissions for excessive crying. So again, this slide stresses how important, how frequently seen these functional gastrointestinal disorders in young children are. So if we look at the specific costs, then there are more than 1 million doctor visits for regurgitation. It's the highest rate in young children to visit an emergency department, approximately $2,500 per patient per year. And here are the costs related to sleeping and crying. And as you can see, UK healthcare costs of at least 65 million pounds only for children with sleeping and crying problems. Does it have an impact on later life? Well, this slide again clearly shows that if you have colic as an infant, then there's an odds ratio of almost 3 to have another functional gastrointestinal disorder later in life. And the same is true for regurgitation and constipation. So this slide shows you that although it's a benign entity, it doesn't tell you that you won't have problems later in life. And if we look at healthy controls, the odds ratio is, of course, in this group of patients much higher. How does it relate to family life? Well, you can imagine that it indeed has major impact on family life, because it has been shown in different studies that these entities give feeding difficulties or even discontinuation of breastfeeding. There's significantly more parental stress, even depression and insecurity about the infant. If we look at the long term, there are more behavioral and developmental challenges in these children. And as you can understand, that there's a challenge on family quality of life 3 years later after having these problems. And as I showed you already in one of the slides before, there's a higher chance on having FGIDs later in life. Okay, so let's switch now to the 3 most important clinical entities, of which I will discuss regurgitation first. So the definition is not that difficult. It must include all of the following in otherwise healthy infants 3 weeks to 12 months of age, and that's regurgitation 2 or more times per day for 3 or more weeks. And there shouldn't be any red flags such as retching, hematemesis, aspiration, apnea, failure to thrive, feeding or swallowing difficulties, or abnormal posturing. And to my opinion, this is one of the most important slides which should be discussed with the parents, because this slide shows you the natural history of regurgitation. And this was done in a group of almost 700 infants who were followed for a year. Because as you can see from this slide, that the peak of the regurgitation is after 3 to 4 months. And in this study, it was like 40%, but to my opinion, it's probably much higher, because most of the children will have a regurgitation because it's just a physiological phenomenon. But why is this slide so very much important? Because as you can see, at the age of 12 months, hardly any child of this group of children still have problems of regurgitation, which means that the natural history in these children is completely benign, and this should be addressed and discussed with the parents. So in the next slide, I will discuss with you an algorithm how we look at children with regurgitation, what we do with these children with regurgitation, and how we treat these children with regurgitation. However, I want to stress that this is made by Western doctors, and I'm not sure if you in your countries treat or diagnose these children in exactly the same way, but it might help you in looking in a different way at these children. But I'm very happy to discuss this with you after this presentation. So there is regurgitation, very simple. If you do not fulfill the Rome 3 criteria, then it might not be regurgitation, but really reflux disease. And then it depends on how healthcare works in your country, if you refer these patients directly to a general pediatrician or to a pediatric gastroenterologist. If you think of regurgitation, then the most simple thing to do is to ask about the feeding. So you can ask about the frequency of feeding, the volume of feeding, but also the technique the feeding, the formula is giving. And you know, if you find some abnormalities in frequency, volume or technique, then of course it's very easy to change this. But if you're not sure, or if the mother tells you that everything is okay, then of course we have to look for the red flags, so as failure to thrive, or bloody refluxate, or even back arcing or neurological abnormalities. But we should also ask for irritability, crying, feeding problems, but also for allergic symptoms. And this algorithm was made together with Ivan van der Plas, who wrote a nice paper on the COMIS, in which you can use for children, for infants with allergy. So if, go back to the algorithm, if the frequency or the volume technique is not right, or it has been improved, then you don't have to do anything. You just follow these children and give advice to the mother about the feeding again, or you stop the follow-up after the child has improved. Very importantly is that you also should reassure the parents that most of the children, as I showed you on one of the former slides, that it has a benign course and that the majority of children will not face any problem at the end of the year. However, of course, you can also suggest to use an anti-reflux formula, which is also helpful in some of these children. There is a big discussion going on about positional treatment of these babies. So I think many of you and many of the doctors all over the world suggest to elevate the cot to prevent reflux. However, studies have shown that elevating the cot in very young infants is not helpful at all. So what you might do is put the infant on the belly, but as you know, then there's a chance on sudden death infant syndrome. So that's the reason why we don't advise to put the baby on the belly. We did a study to look at the left lateral position of the baby with respect to reflux and reflux disease, and indeed we found that the number of reflux episodes decreased when putting these children on the left lateral position. However, again, the chance that the child will roll over on their belly is higher, so this means that the chance on sudden death infant syndrome is also higher. So today, if we don't have the right pillows to put the patient in, we have a little doubt to do positional treatment, which means the left lateral position in these infants as well. So there's not a good advice at this moment for positional treatment in very young infants. So what about allergy? Of course, if you look at the algorithms of allergy, then it might be helpful to consider a cow milk-free diet in breastfed babies, or even use a cow milk-free formula. But please keep in mind that it's sometimes difficult to show indeed cow's milk protein allergy. So then we suggest to challenge and follow up according to the protocols which are in the literature for cow's milk protein allergy. So this is almost all about the algorithm for regurgitation. So if we don't have an allergy, then again, if the child has failure to thrive or has hematemesis, for instance, then you have to consider to refer to specialty consultation, because then in those children we might consider a gastroesophageal reflux disease, which might be treated with an acid blocker or even eosinophilic esophagitis. And I have no idea how many times per year you see these children in your daily practice. But what we do know now is that in the United States, they more and more see these children. If we compare this to the situation in the Netherlands, we yearly face approximately 5 to 10 children with reflux, which is based on eosinophilic esophagitis per year in our hospital, which still is much less compared to our colleagues in the United States. So this is what I wanted to tell you about regurgitation. So please look at the algorithm again, and if you have any questions, please ask them and use the algorithm, what you think is good about this algorithm, but please use your own strategies as well. Okay. So what about algorithm for reflux disease? Well, these are two nice papers from Italy and the UK, and their approach to infantile reflux symptoms. And as we know that most of the PPIs prescribed have side effects for these children, although they are not that bad, it's still in the literature that you can have side effects such as more infections and other side effects. So we do know that there are side effects, but still almost 60% of these pediatricians in Italy prescribe PPIs in children with colicky symptoms. So there was even no diagnosis of reflux disease, but they still prescribed PPIs because they thought that the colic symptoms were based on reflux or regurgitation. Which means there's an 80% overprescription of PPIs in these patient groups. And although there are not many very good studies in children with reflux disease or colic, there are some really good studies showing that PPIs in these children have no effect at all compared to placebo. So the strict advice from the important committees like the ESPGHAN and the NESPGHAN guidelines don't prescribe PPIs in these children. And this is also a little sad to discuss with you because as you know, writing a guideline takes a lot of time. You have to perform an extensive literature search, then discuss the literature together with important people in the world who are very knowledgeable about the particular topic, and then finally you write this large paper including diagnostic algorithms and treatment algorithms. But as you can appreciate from this slide, only 2% of the doctors in Italy showed complete adherence to these existing guidelines, and this is probably true for many countries. So sometimes I think by myself, why do we do all the work? Because nobody reads it at the end. Okay, this is another paper from New Zealand where we can see exactly the same data as from the Italian study. PPIs were prescribed in a large proportion of babies who were younger than 3 months of age. But again, very surprisingly, the majority of these infants didn't show any sign of reflux disease, but still were given PPIs. And as I showed you in one of the slides before, these PPIs can give rise to side effects. Okay, so this was the topic of infant regurgitation. The next topic, also very common all over the world, is infant colic. And to my opinion, this slide is also very important to explain to the parents. The two papers were published in different areas, in different time points. This is a study by Brazelton, which was published in the 60s, whereas Barr published the same data in the 90s, because the scale between the two graphs is different, but the outcome is exactly the same, which means that after 5 to 6 weeks there's a peak in crying time, approximately 2 to 3 hours per day in healthy infants. So this should be discussed with the parents, where you stress that this is a very common symptom in young children, and as you can see, after 12 weeks most of the crying has disappeared. So now there are two schools of thought as expressed in this slide. One of them is made by Ian St. James Roberts, who is a psychologist working in the UK, and he was a member of our group. And he made life sometimes really, really difficult for us doctors, because he over and over again told us, you pediatricians, don't worry, it's not a disease, it's just a developmental phenomenon. So you don't have to do any treatment, or you don't have to do any diagnostic testing, because it's unnecessary. It will disappear, as is shown in the graphs before. But of course there are also schools, and this is a paper from Indrio from Italy, where it's said that colic has a gastrointestinal origin, so it might be related to the maturing gut, or is sensitive to substances as lactose, for instance. But it might also be related to reflux disease or even constipation, or it might be caused by an interaction between the microbiome and the gut. But again, as I told you in the former slide, this psychologist made life difficult for us because he said, "Don't worry, the colic will disappear after approximately 4 to 5 months." Okay, so how did we define colic in the old days? Well, Wessel from the United States in 1954 already had a very nice rule of 3, so which means 3 hours per day of crying 3 times per week during at least 3 weeks. However, again, the psychologist told us, how do you know it's true? Because the questionnaires used at that time were very difficult to validate. And moreover, what was also very important to him, he said, okay, let's look at an infant that's crying so much. So if the infant cries 2 hours and 50 minutes per day, then we don't call this a infant colic. Only if it cries more than 3 hours per day, we can call it infant colic. Well, I don't know. He also said crying is cultural dependent, and more importantly, he said it's not possible for mothers to keep a specific diary where she really calculates how many minutes per day an infant cries. And that for more days is even more impossible. They have more to do than just calculate how many minutes a day a child cries. Okay, so this made it very difficult in our group because we respected his opinion, which means that we liked his idea that it's a developmental phenomenon. But on the other hand, you have to do studies, because if companies start to have a new formula or have a new treatment, then you want to compare baseline with the end of the study. So, well, we finally decided to have 2 definitions for infant colic. So what's listed on this slide is that for clinical purposes, infant colic must include the following: an infant who is less than 5 months of age, who has recurrent prolonged periods of infant irritability, fuzzing or crying, either reported by the parents or by the caregivers, that occur without obvious cause and cannot be prevented or resolved. And of course, as is mentioned in all criteria for functional gastrointestinal disorders, there's no evidence of failure to thrive, fever, or ill health. Okay, so again, this definition can easily be used by parents, but also by all kinds of healthcare professionals, because this is what infant colic is. However, if you really want to do clinical research, then we are more strict, because then we really need good validated questionnaires with a telephone or face-to-face screening interview with a researcher or a clinician. But not only that, we also need to look for a 24-hour crying diary, for, if possible, for more days, to really calculate how many minutes per day the infant cries. And if we use these more strict criteria, then we can compare treatment, which is nowadays advised for infant colic. So the next question is about treatment, of course. So who shall we treat? Is it the father? Is it the mother? Both? Or is it the child? It's a very relevant but difficult to answer question. And as I showed you before, infant colic has a huge impact on family life. So this is a study published a few years ago, because they compared heavy criers versus control, and they looked at the interaction between the parents and the child, and they found that especially between both parents and the child, the interaction was less optimal. And the same was true not only for the mothers, but even between the fathers and the infants in particular. And as you can understand that this is just normal life, where the mother and the father not always have the same opinion about things, that even in these very difficult circumstances where you have less sleep and are more tired, that there is less optimal interaction between the parents as well. Another paper about crying and family function. So as was listed in the former slide, dissatisfaction with family life, but also more sleeping problems and temper tantrums and distress in the child. And there was higher levels of parenting stress, more postpartum depressive symptoms, and a shorter duration of full breastfeeding. So these slides clearly show you how much impact infant crying has on daily family life, but also very important between parents and between the interaction between parents and their infant. Again, I will now discuss with you an algorithm which was made again together with Ivan van der Plas about infant colic. And again, I hope you will use your own practice as you're used to in your countries, but this algorithm might also be helpful to think about infant colic in a little different way. So first of all, we look at the criteria for infant colic as listed here on the right side of the slide, and we also look for warning signs like back arcing, bleeding, failure to thrive, and other signs for organic disease. But as you know, in the majority of children with crying, less than 55% of the children, less than 5% of the children face organic causes for infant colic, and in these cases, urinary tract infection is probably the most common cause for infant crying. So if there's yes, then you might refer to a general pediatrician or even to a pediatric gastroenterologist for looking for specific disorders. But on the other hand, like in regurgitation, we might look for allergy in these children, because if we look at the algorithm for infant colic, then it might be helpful to change the diet after a certain time and use a cow milk free diet in breastfed infants, or even use a hypoallergenic formula in children who you suggest to have a relation between crying and the formula. If you have improvement, then you're lucky, because it's only a minority of children, and you can maintain the support of a cow milk free diet. But keep in mind that you need to have a challenge. This is probably the most important part of the algorithm, because as I showed you, infant colic can have a major impact on family life, which gives not only lots of tension between the parents, but it can even leads to anxiety in parents, in parental depression. And there are papers in the literature which show that after 5 to 6 weeks, which is probably the peak of crying time, there is more risk of child abuse. And please keep this in mind, because if you feel that the stress is so high in these families, we always suggest to take the child either in the hospital or ask other family members to take over the help of the little infant, because then it probably decreases the tension in the houses of these families. So although it's very difficult to suggest this to the mothers, because they often feel this as a failure, we stress that it has nothing to do with failure, but with getting exhausted and not being able anymore to give breastfeeding or give the same attention to the infant as was the case in the first weeks of life. So to my opinion, this box is probably the most important box in infants who cry so much. Okay, then I have no time to discuss this with you. And normally when I see the patients in real, but I know it's not the case right now, I ask the audience how many of you consider a probiotic to be used in these children. And although many of you probably will say, no, we never give a probiotic, I always say, well, I don't believe you, because today many of the doctors indeed give a probiotic for these children. But is there any evidence? And yes, there is. There are now, I think, 8 studies on the effect of the Lactobacillus reuteri in these children. And there are some very positive studies, but there are also some negative studies on the efficacy of the Lactobacillus reuteri in infants with excessive crying. So again, please look at the literature. Think about the probiotic you prescribe in these infants. There's hardly any data on whatever other probiotic in infant crying. And please also look at the data now about the efficacy of the Lactobacillus reuteri, since they are different in the different papers. But again, some people like it to prescribe it particular strain, and they have the experience that it's helpful, but please be critical. Okay, so this is about infant colic. So the last part of the presentation, I will discuss the defecation disorders. And as I heard that more than 200 people are now listening to this presentation, and as you are coming from really different parts of the world, the different pictures on this slide might be true for your country. Okay, so again, this is, to my opinion, again, a very important slide which you should discuss with your patients, because it only shows you what the normal defecation frequency is in very young children, but also in the older children. So there's a difference in the first month of life where there's really frequent defecation, but we have to acknowledge that at the age of 3 years, the defecation pattern is almost exactly the same as in adults, which means that a child of 3 years of age defecates 3 times per week to 3 times per day, as an adult also does. And this is frequently in contrast what the mothers think about defecation, because they think that only daily defecation is a healthy phenomenon in their child. And this is not true. As I told you, if you defecate 3 times per week without any other complaint, then this is the normal defecation belonging to that particular child. A small, I will shortly discuss functional diarrhea, because in the last 25 years nothing has changed in the criteria for functional diarrhea. There's no new data on this particular entity. It's the daily painless recurrent passage of 4 or more large unformed stools, and the most important thing is that there's no failure to thrive if caloric intake is adequate. And as you can appreciate, the symptoms last for more than 4 weeks but disappear after the age of 5 years. We eliminated this sentence that during sleep there couldn't be any defecation, but however, literature shows that 25% of the children indeed have a bowel movement when sleeping. The good thing, if you have made the diagnosis functional diarrhea, then you don't have to do anything. You reassure the parents and wait and see what's happening. You might increase the fiber and fat intake, but that's the only thing you need to do. Reassure that the symptoms disappear after the age of 5 years of age. So now I'm coming to the last part of the presentation, which will discuss the functional defecation disorders. And to my opinion, if you have a good medical history, you do a little physical examination, then in more than 95% of these young children have a functional defecation disorder. And of these, 95% of the children will have functional constipation, and a minority of children will have infant dyskeysia. I have no idea if you are familiar with the term infant dyskeysia, but it was also mentioned already in the 2006 gastroenterology paper in infants and toddlers. But if I show you now the symptoms belonging to infant dyskeysia, then you will say, haha, of course I know this. Because it must include at least 10 minutes of straining and crying before unsuccessful but also successful passage of stool. So these children have a little problem during defecation, but after they defecated, which is completely normal, the symptoms disappear. And of course they shouldn't have any other health problems. And first of all, it could be there until the age of 6 months, but a study in the Netherlands performed showed that even children 9 months of age could have these symptoms as well, but at the end all of them disappeared. And we also looked at the development of constipation in these children, but this was not related to infant dyskeysia in the first year of life. To be honest with you, we don't have a clue what it exactly is, but we as doctors like to have an explanation for everything. And I think that if you make a very difficult explanation, patients even more like that, because then they think, oh, this doctor is really, really intelligent. He comes up with a very good and very difficult explanation. He must be really, really clever. So this is what we made for you as doctors. It might be a failure to coordinate increased intra-abdominal pressure with relaxation of the pelvic floor. I hope you can remember this sentence, but if you explain this to your parents, I promise you, you will have a big success. Of course, we are not able to really test it if this is true in the lab. So what's the treatment of infant dyskeysia? Well, for the parents, as I told you, reassure them, educate them using the former sentence, and ask them to be patient, because the symptoms will disappear within the first year of life. And for the baby, luckily nothing. So don't use massage, don't use a thermometer, and again, or you don't have to use laxative in these children as well. So the last part of the presentation will discuss constipation, and as shown from this slide, constipation is really everywhere. We did a large systematic review, and I'm always surprised to see and to learn that wherever you live on this planet, the prevalence of constipation in young children, older children, and adolescents is almost exactly the same. Even if you look at the rural and non-rural areas in the world, if you live in the West or in the East or in Africa, everywhere prevalence of constipation is the same. And this makes it a little difficult to understand why this is, because many people relate constipation to feeding, especially fibers, for instance. But until now, we can't make this clear conclusion, because, as you know, the diets in Africa or in the Netherlands or in Brazil are completely different, and still the prevalence is exactly the same. So here is the definition for functional constipation. It's very easy to work with. It's almost the same in all age groups, and it contains infrequent bowel movement, which is most of the time painful or hard, and in some of the children they have a history of large diameter stools. And if you do a physical examination, which is not always performed in all countries, you might find the presence of a large fecal mass in the rectum. But in the new criteria, it's listed that if you have two symptoms of constipation, it's not very necessary to do a rectal examination. Very importantly is to ask for withholding behavior, because as you know, in the young age, withholding behavior is probably the most important cause of constipation. On the bottom of the slide you can find some sentences about toilet training, because of course there's a difference between those children who are toilet trained and those who are not toilet trained. Don't think you can read this slide very properly, and you can't even read the next slides properly, but if you're really interested in the algorithm of constipation, then please go to this paper, which was published in 2014 and is the guideline made by the Esfagen and Nesfagen, and discusses everything what is related to constipation, about symptomatology, about diagnostics, and about treatment. But of course, for this particular presentation, I made a very simple algorithm which might be useful in your daily practice as well. So first of all, we have to look for the warning signs, because in approximately 1% of all children with constipation, it's related to an organic cause of constipation, and in most of these children it's either Hirschsprung's disease, hypothyroidism, or even cystic fibrosis. And the symptoms related to these particular disorders are, of course, meconium production, which is normally true in 99% in the healthy children within 48 hours, but also look for failure to thrive, bloody stools, and of course anatomic abnormalities. So if they're yes, then for sure you should refer these patients to a gastroenterologist or even to a pediatric surgical hospital. If not, then please ask if these children are breastfed, because as you know, approximately 10% of the breastfed children have an infrequent defecation without any other symptoms. Again, in these children you don't have to do anything, but this might be the reason why these children have infrequent defecation. So you just reassure and educate the family. If it's not, then again, like in regurgitation, ask about how mothers make the formulas, because as you know, if there's an imbalance in the volume of the formula with the powder, then it might be the case that the young child get constipated. If this is very normal, then probably the child has functional constipation, which I showed in one of the first slides to be the main reason why children are constipated. And then the most important, this is too quick. So this box is probably the most important one of this algorithm. Please, please, please use a laxative as soon as possible. Don't use a wait and see policy. Don't add oil to the formula of these children. Don't give them additional water if their water intake is already sufficient. No, please start a laxative. And it depends on wherever you live. If you like to give a polyethylene glycol or lactulose, they're both very effective. And if you do so, then approximately 80 to 90% of the infant with constipation, the symptoms will resolve within 2 months. Whereas a paper clearly showed that if you follow a wait and see policy, then approximately 60% of these patients still have constipation after 3 years of life. Also, in a minority of cases, you might think of changing the formula to a hypoallergenic formula. Just follow these children, because you have to really see if symptoms disappeared, and if not, then you might refer the patient to a specialty consultation. So this is the last slide of the presentation. I showed you the different categories like regurgitation, infant colic and constipation, that explaining what the disease is might be really helpful. Reassurance is in most of these cases very helpful, and as I showed you, there are algorithms available how to diagnose and how to treat these children. Hopefully the Rome 5 criteria will include feeding disorders, will include more outcome studies for different clinical entities, and of course it might be very helpful to have these studies performed in your parts of the world as well. Thank you very much for your attention. This was the presentation. Don't raise your hand because I can't see it if you raise your hand, but please send the questions to this system. Thank you very much. So I don't know if you're thinking of questions right now, but before, in the days before, there were already some questions from doctors in Asia. The first question is, what is about constipation during early month of baby with breastfeeding milk? Well, I already told you that in many of these children, approximately 10% of these children, indeed they have infrequent defecation. But if they don't have any other sign of constipation, you don't have to do anything. But if so, and you still think of functional constipation, then I suggest to add a laxative and add it besides the breastfeeding. So start it as early as possible. Then the second question was how to manage infant regurgitation in restricted healthcare facilities and optimizing nutrition care for babies with cow's milk allergy. Well, it's two questions in one. So how to manage infant regurgitation if the child thrives well but has infant regurgitation, please don't do anything, because the study showed that any change, that any drug is not helpful in these children. The first advice to all of you is please ask about the techniques of feeding, and if everything is normal, then you can give advice to thicken the feeding, and that's it, to my opinion. And then again, there's a big discussion going on about the relation between allergy and regurgitation. However, if you strictly read the guidelines, then they suggest if you have only one symptom which might be related to allergy, then the chance is not that high that the child indeed has cow milk allergy. So if only one organic system is involved, I don't think it's that necessary to give another formula. But I can understand if mothers insist that you try to change the formula, that sometimes if you are not well, can really make them happy that you sometimes change the formula. But again, the chance that it's really related to cow's milk allergy is only little. The prevalence of FGIDs in Asia, and are they really an issue? Well, that's up to you. I'm living in the Western world, and we face it every day. But to be honest to you, I gave presentations in Sri Lanka, and I gave presentations in China, and I gave presentations in Vietnam. And as I listened carefully to all these doctors, again, they see as many young children with these problems. And again, if you have enough knowledge of the particular topic and you are able to reassure the patients, then it's of course no problem at all. And it's our responsibility as healthcare professionals not to prescribe too many drugs if we know it doesn't work. And the same is true for probiotics. We need to know what strain we use, what the properties of these strains are, how they work, and if they are useful in whatever gastrointestinal disorder. And if you read the literature properly, there are only, well, few strains at this moment available which are really helpful in whatever gastrointestinal disorder. Okay, then I have questions here. Does breastfeeding babies also experience constipation or colic? Yes, the answer is very easy, that's yes, and then treat accordingly. Of course, there's always a question what to do with mothers who give breastfeeding. It might be helpful to ask them to use lactose not as much as they did before. So they probably should leave out lactose in their normal diet. Then the next question is, in your practice, what is the treatment of idiopathic constipation? Well, as I stressed, I listen carefully to the patients, and then if I indeed make the diagnosis functional constipation, I have no problem in starting a laxative as soon as possible. Lactulose or even polyethylene glycol has shown to be very helpful, and not only that, there are hardly any side effects prescribed of these drugs. Of course, there's a difference between the side effects as mentioned from lactulose, because as you know, lactulose gives rise to sometimes abdominal distension, an increase in flatulence, and abdominal pain. But on the other hand, many infants do really well on lactulose. And if lactulose is not very helpful, we switch very early in the course of constipation to polyethylene glycol. A study from Vera Luning-Borg from the United States showed that even after 1 day in life, polyethylene glycol is helpful and showed no side effects. Please give it then for at least 2 months, because as you know, constipation is in many, even babies, related to the production of hard stools and therefore withholding even in babies, and you want to get rid of the negative association of the baby with hard stools and defecation. So that's the reason why we suggest to at least use a laxative for 2 months and then taper the medication very slowly. There's no reason to do it in a very fast way. A lazy gut probably doesn't exist, and I'm not afraid to give laxatives as long as needed. Is there a limit to how long we can wait for in a well baby on exclusive breastfeeding without any other symptoms? No, because if the child who's receiving breastfeeding thriving really well, has no other symptoms of constipation or colic or whatever, please don't change the exclusive breastfeeding, because as you know, breastfeeding is better than formula feeding. What's your opinion about the use of magnesium hydroxide as a laxative? It depends on the age of the child. There are again many studies showing that it's a very effective drug, and again I'm not sure about this, but we give magnesium hydroxide from the age of 2 years, but there are now formula on the market where there is which contain an increased concentration of magnesium, and it has been shown in these studies. There are, I think, 3 on the market now, or in the literature now, which shows that magnesium itself in the formula also is very effective for young children with constipation. But again, I'm not sure about magnesium hydroxide itself, when to start this drug, but this must be in the guidelines. Does partially hydrolyzed formula really reduce incidence of colic in infant? That's a difficult question as well. Again, the literature is scarce on this topic, but the literature until today indeed shows that hypoallergenic formula are probably helpful in children with colic. So indeed, the advice is if you have a reason to believe that there is an association between the diet and colic, then you might switch to a partially hydrolyzed formula. I don't see any other questions. I have no clue how long I have to wait for other questions. Otherwise, I wish you a very good day, and I wish you a very fine day, and hopefully I have answered all your questions, and hopefully this presentation, especially the Rome 4 criteria, are helpful for your daily practice. Okay, good afternoon.